Hello, my name is Dr. Diwan S. Raja. Today I will discuss about the palatine tonsils. The palatine tonsils are lymphoid structures. They are found in the oropharynx between the palatoglossal fold and the palatopharyngeal fold in the tonsillar sinus. So if we go there, the palatine tonsils are a component of the Waldear's ring of tonsils. Okay. The palatine tonsils are located in the oropharynx bounded by the oropharynx in the tonsillar sinus, in the tonsillar sinus, okay. Bounded by the palatoglossal fold, and the palatopharyngeal fold. So we got the palatine tonsils. They are a component of the Waldear's ring of tonsils. We know that Waldear's ring of tonsils are present in the oropharynx and nasopharynx. We have the palatine tonsils, lingual tonsils, pharyngeal tonsil, and the tubal tonsils. The palatine tonsils, we have two palatine tonsils. They are located in the oropharynx on each side in the tonsillar sinus, bounded anteriorly by the palatoglossal fold, posteriorly by the palatopharyngeal fold. So we got the palatine tonsil, its location. Each palatine tonsil has lateral surface, okay, that rests on the tonsillar bed. Okay, medial surface, we have the upper pole, lower pole, anterior border, and posterior border. palatine tonsil has lateral surface. So this is the lateral surface. Lateral surface. Medial surface. This is medial surface. The upper pole is here, lower pole is here. We have also anterior border that is overlapped by the palatoglossal fold, posterior border that is overlapped by the palatopharyngeal fold. We got that? The tonsils are, they looks like an almond or almond, okay? They are almond or almond shaped lymphoid structure. Okay. And if you go to the medial surface, medial surface has about 12 to 15 crypts. Okay, about 12 to 15 crypts. Okay, so these are the crypt. This is a crypt here. This is a crypt. We have crypt here. Okay. Okay. The crypts are also branched out. The crypts have also branches. We have secondary crypts. We get secondary crypts. We call it secondary crypts. One of the crypt is very large. It is called intratonsillar crypt. Okay, that is called intratonsillar cleft. It is called intratonsillar cleft. Okay, that is the largest of all, very large crypt. This is the intratonsillar cleft. It is also called crypta magna. Crypta magna. We got the crypts. The crypts are lined by stratified squamous non-keratinized epithelium. All the crypts are lined by stratified squamous non-keratinized epithelium. Okay, crypts are lined by non-keratinized stratified squamous epithelium. Okay, we got the crypts. They are lined by non-stratified squamous epithelium. We got the, what are the contents of the crypt normally? Contents of the crypt. The crypt contains dead or live lymphocyte, both B lymphocyte and T lymphocyte, live lymphocytes. Okay, epithelial debris. Epithelial debris. Okay, even it may contain some food particle. If it is inspissated inside the cleft, there may be little stone formation. Okay, and epithelial debris, dead and live lymphocyte. We may have also common cell bacteria there. Common cell bacteria. Okay, so even we may have food particle if hygiene is not properly maintained. Food particle may be impacted there. Okay, and in case of tonsillitis, certainly will get pus in tonsillitis. These are the contents of the crypts. We got the crypts. Crypts are present on the medial surface of the tonsil. This is the lateral surface. Lateral surface is covered by a capsule. The lateral surface is covered by a hemicapsule. We call it hemicapsule because this capsule is just present on the lateral surface, part of the superior pole area. Okay, it does not cover the medial surface. So this is the capsule. This is the capsule. It is called a hemicapsule. It is not complete. It is a tonsil. It is not totally encapsulated. It is a tonsil. The Palatine tonsil. It has only efferent lymphatic ducts. It has only efferent lymphatic function. It has no afferent lymphatic function. Okay, so the capsule that is derived from pharyngobasilar fascia. Okay, it is a derivative of pharyngobasilar fascia. We got the capsule. Then we'll go to the lateral surface. What structure forms the tonsillar bed? Tonsillar bed. Okay, we can say the capsule again. We have the superior constrictor muscle. And the styloglossus muscle. And if you consider the relationship, these are the structure forming the tonsillar bed. If you go to the relationship on the lateral surface, relations of the lateral surface, okay, of the lateral surface, then we add few more things. The palatopharyngeus, okay, and we have to add the buccopharyngeal fascia, and certainly the ninth cranial nerve or glossopharyngeal nerve. Okay, these are related to the lateral surface of the tonsil. Okay, we got the tonsillar bed and other structure associated with the lateral surface of the tonsil, the palatine tonsil. Okay, that is the relationship. Okay. We may get two plica. Okay, you can get two plica or fold of mucosa. Okay, plica. One is plica triangularis. Another one is plica semilunaris. Semilunaris. Okay. What are these? their vestigial mucosal folds. Okay, this we found in the lower part here, and plica semilunaris in the upper part. We got that plica. These are thin vestigial mucosal fold. We may get that. Okay, we got the plica triangularis, plica semilunaris. Now we'll go to the blood supply. That is very important to us. Blood supply of the tonsil. We can say of the palatine tonsil. Okay. Number 1, tonsillar branch of the facial artery. Tonsillar branches of facial artery. Okay. So these are the tonsillar branches. These two are the tonsillar branch of the facial artery. If you can write it 1 here, number 1 is tonsillar branch of the facial artery. Then we may get the ascending palatine branch of the facial artery. Ascending palatine branch of facial artery. Okay, and we know that facial artery is a branch of the external carotid artery. Ascending palatine branch, so that should be, this is the ascending palatine branch. Ascending palatine branch, you can put it 2. Then tonsillar branch from the ascending pharyngeal artery. Tonsillar branch of, maybe branch of ascending pharyngeal artery. That is a branch of the external carotid artery. This is this. Number 3. Then we'll get dorsal lingual branches, tonsillar branches from the dorsal lingual arteries. Dorsal lingual arteries. These are branches of the lingual artery. This is lingual artery. Lingual artery. These are the dorsal lingual branches. Dorsal lingual branches. Okay. So we got the dorsal lingual arteries that provide the blood supply to the tonsil, and certainly we get the, this is the greater platina, this is the maxillary artery, and we have the greater palatine artery, greater palatine artery, branch of maxillary artery, greater palatine artery that also provide blood supply to the tonsil. Greater palatine artery is a branch of maxillary artery. Maxillary artery is a branch of external carotid artery. Okay, so we got the greater palatine branch to the tonsil. But most important is the facial artery. This is the facial artery. Okay, it's tonsillar branch. Facial artery. We got the blood supply. We got the arterial supply. Okay, these are the arterial supply. Now we'll go to the venous drainage. Okay, so we got number 5, is the greater palatine artery. So we got the blood supply of the tonsil, tonsillar branches of the facial artery, ascending palatine branch of the facial artery, tonsillar branch of ascending pharyngeal artery, dorsal lingual arteries, greater palatine artery. Okay, they all supply the tonsil. Okay, we got the arterial supply. Now we'll go to the venous drainage. The venous blood from the tonsil goes to the goes to the pharyngeal veins or plexus, pharyngeal plexus of veins, okay, palatine veins and facial veins. Okay, we got the venous drainage of the, so it is in the oropharynx, so it should go to the pharyngeal veins, pharyngeal venous plexus, palatine vein, it is related to the upper pole is related to the soft palate, lower pole is related to the tongue area, the posterior third of the tongue here. The capsule is also blended to the lateral aspect of the tongue. Okay, we got the venous drainage, pharyngeal plexus vein, palatine vein and facial vein. One important point regarding the capsule, just outside the capsule we have loose areolar tissue between the capsule and the tonsillar bed. We have loose areolar tissue, loose areolar tissue that contains paratonsillar vein, okay, you can call it peritonsillar vein, better to say peritonsillar vein that passes in the loose areolar tissue, okay, that may be damaged in tonsillectomy. Okay, we got the peritonsillar vein. Okay, so we have the venous drainage to the pharynx, to the pharyngeal veins, to the peritonsillar vein, to the facial vein, and also the peritonsillar vein that also pick up some venous blood from the tonsil. So pharyngeal vein, we have the palatine vein, we have the facial vein and peritonsillar vein. Okay. We got the venous drainage, arterial supply. Now we'll go to the nerve supply. Nerve supply or innervation to the tonsil of the palatine tonsil. Okay, we have the nerve supply is the glossopharyngeal nerve, or ninth cranial nerve is important, clinically important, because if the child has tonsillitis, then he or she might have pain in the middle ear cavity, because the otitis media also, the middle ear cavity or the tympanic cavity also receive the innervation from the glossopharyngeal nerve. Okay, so it also get innervation from lesser palatine nerves. Okay, we got the nerve supply. Now we'll go to the lymphatic drainage. So we have two nerves, glossopharyngeal nerve, lesser palatine nerve, innervating the tonsil. Okay, we have to go to the lymphatic drainage. Lymphatic drainage, you have to remember that Lymphatic drainage is mostly goes to the gigulodigestic lymph node, a group of deep cervical lymph node. Okay, it goes mostly to the gigulodigestic lymph nodes. Okay, so if any inflammation in the tonsil, we may have enlargement of the gigulodigestic lymph node. People say this is the tonsil. This is not the tonsil. This is the gigulodigestic lymph node. Tonsil is present in the oropharynx between the palatoglossal and palatopharyngeal arches, and it can be visualized by putting light inside the mouth cavity. Okay, so gigulodigestic lymph node is present here. That is the area for lymphatic drainage from the tonsil. Okay, we got the lymphatic drainage. Now I'll go to the histology. Okay, histology, we discussed this. The crypts are and the surface, medial surface and crypts. Medial surface and the crypts are lined by non-keratinized stratified squamous epithelium with some patches of reticular epithelium, with some patches of reticular epithelium that is associated with immunological function, because we know that this is a lymphoid organ, so it produces lymphocytes, both B and T lymphocyte, mostly B, but certain time it also produces T lymphocyte. We got that. The lining epithelium, then we'll go, it is the lymphoid tissue, we'll get lymphatic nodule, and we may get germinal center. Okay, we'll get germinal center, lymphatic nodule. Okay, lymphatic nodules. We may get germinal centers. Germinal center in the lymphatic nodule. Okay, so we got the histological structure. The lining epithelium is non-keratinized stratified epithelium plus some patches of reticular epithelium, and we have connective tissue stroma, and the capsule is a fascia. Okay, but we have lymphatic nodule that contain germinal center. Okay, we got the histology. We go to the embryology. Embryology or development. Okay, the tonsil is developed, we can call the palatine tonsils. Are developed in the second pharyngeal pouch. Okay, we can call it branchial pouch also. Pharyngeal pouch and branchial pouch are same thing. Okay, we got that. It is developed in the second pharyngeal pouch. Okay, and epithelium are endodermal. The lymphoid tissue lymphoid tissue or nodule, okay, that is mesenchymal. Mesenchymal. What is mesenchyma? Mesenchyma is the embryonic form of connective tissue. Okay, we got the development of the tonsil. Then we have to know some of the age changes in the tonsil. Age changes. Tonsils are comparatively larger in the children. After puberty, it begins to atrophied. Okay, in the adult, it is much atrophied, and tonsil does not totally occupy the tonsillar sinus in the adult. It will shrink. Okay, so age changes. It is large in children. Okay, and it is smaller, comparatively smaller in the adult. These are the age changes. Now we learn some of the clinical anatomy. Clinical anatomy is important to us because a lot of us already our tonsil has been taken out by the ENT doctor or otolaryngologist, and tonsillectomy is a very common practice. Okay. Tonsil is a site of inflammation. We call it tonsillitis. Maybe bacterial, maybe viral. Okay. Around the tonsil, we might have peritonsillar abscess. We call it quinsy. Peritonsillar abscess, also called quinsy. Okay, and it sometimes begins from the base of the intratonsillar cleft, the large cleft, crypta magna. From here it extends. It is around the capsule, and it needs drainage by the ENT doctor or the expert physician to take out the pus, and then they do the tonsillectomy eventually if it is required. Okay. We got the peritonsillar abscess, very common condition. Okay, so tonsillitis, and tonsil may be the septic foci for tuberculosis, especially in the overpopulous countries. Tuberculosis, and also it is a foci for meningitis. And we must know that in certain percentage of children, if they have tonsillitis, that may cause rheumatic fever. Even some of them may develop glomerulonephritis. Okay, nephritis. Not common, but it is possible. Okay, so, and tonsil, again, it is a tissue. We may have very rarely we may have tumor development or cancer formation in the tonsil. That is very rare. Okay, so that's all about the anatomy of the tonsil, and also we have gone through the blood supply, lymphatic drainage, nerve supply, histology, development, tonsillar bed, lateral, the relationship on the lateral aspect of the tonsil, and certainly the clinical anatomy. So if you like my video, please support my channel, please subscribe me, and please share the information with your friends. Have a nice day. Bye now.